So there's a couple proven ways to help decrease tears. One is...
Hello and welcome back to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good, reliable knowledge because the source of your information matters. My name is Eric Schmidt. I'm a board-certified OBGYN, and I have back with me Dr. Amy Buben.
Hi.
I was waiting for it.
Oh, yeah.
No, it's okay. It wasn't me. Anyway, please consider downloading and following along. We're on all the podcast hosts and on YouTube if you want to catch some video podcasts, because I think we're going to have some drawings included in that for you. All right. Amy, what do you want to talk about today?
That was totally spontaneous. I was thinking of obstetrical lacerations.
Oh, that is perfect.
Or tears that happen.
we have that written out right here for you. So we're going to go over obstetric lacerations or lacerations that are associated with vaginal delivery. What we'll go over today, what are they, how do they happen, the classification of the different tears that you can get, and we'll even talk to you about how you can prevent them and different management tips afterwards to hopefully make it more comfortable and the recovery easier going forward.
Yeah. So tears are super common. About 70% of women who are undergoing a vaginal delivery may have an injury or a tear, and they can be in a lot of different areas. So really anything around where the baby's head comes out, so that be the top of the vagina, the bottom of the vagina, the sides, can have tears. This can occur for multiple different reasons. Oftentimes it's just that stretch that's on the vaginal opening as baby is born. Mm-hmm. It can be because of extremities or other things that are delivered at the same time, but we'll get a little bit more into how we can prevent it and help decrease that risk.
Yeah, because it's one of the biggest fears I feel like people have when they're going into their first delivery. And a lot of this is if someone's going to have a tear or potentially a larger tear, usually it's the first delivery, and less chance in the subsequent deliveries. So, let's go over what exactly increases our risk for vaginal tearing or tearing to the surrounding structures, and most importantly, how do we prevent the more severe tears, what increases our risk of the more severe tears? Let's talk about that. Go ahead, Amy.
Yeah. So when we're talking about severe tears, we're talking about, so there's 1 through 4 on the tear scale, and 3rd and 4th is where you kind of get closer to the anus. So that's where we're talking about the more severe tears, but things that increase it. So just anatomy, patient's anatomy, how big the vaginal opening is, how much stretch and give there is, how big the baby's head is, how tight that area is. So if you have a very tight pelvic floor, perineal body, it could potentially increase tearing. Although in pregnancy, women's bodies naturally relax that area. And so if you're not pregnant yet and you're looking and you're like, oh my gosh, I'm going to tear terribly, it changes during pregnancy. Just keep that in mind. Yeah,
we've talked about like the different hormones of the pregnancy, which can cause relaxation of the tissues and structures around. And so this is where one of it may, that benefit may be with relaxing.
Absolutely. And then with the severe tears, sometimes they're just unpreventable, and that's just what happens. Again, women have been having babies for millennium, and this area heals really, really well because it's meant to be able to tear if needed. But there are a few risks or things that can increase it. So operative deliveries like forceps or vacuums can increase the tear risk potentially. And
what's your thought on that? You made a face. I want to know your thought.
Well, I kind of think it's twofold. I don't know exactly the reason why it would potentially increase it. With the forceps, you're now increasing the diameter of what's in the vagina and coming out of the vagina. With a vacuum, you're not necessarily doing that, but sometimes, so vacuums are not easy things from a physician's or from a provider standpoint to do. And so while you're concentrating on being able to deliver the baby safely, sometimes the perineal support may not be there quite as much, or you're forcing...
Your focus is elsewhere.
You're focusing, yeah. Or you're forcing not forcing, but helping along a head that may have had some difficulty fitting in the first place.
Part of the reason why I asked you, and one, I saw you kind of pause there, but I also have a lot of thoughts on it too.
Yeah, go for it.
Because, the best studies aren't perfect. And so they probably did this study and looked and saw that, this person had a forceps, or this person had a vacuum, they had a tear. But, we do vacuums and forceps only in a select few number of deliveries. And spoiler, we'll talk about this in the future, but, if you're doing an operative delivery, I prefer the vacuum, but usually that patient has either been pushing for a long time, and so there's increased swelling, and usually that swelling of those tissues increases the chance of that area, potentially tearing because that tissue is a little injured by the swelling. And so I think those are situations where someone is already set up for a potential tear. Maybe the delayed delivery is going a little slower because of baby being a little bit bigger. It's usually the first delivery if someone's having a vacuum. It's pretty less common to have one in, potentially subsequent pregnancies unless it's for a baby concern. And that's really the other big reason why we might do a vacuum or forceps is baby's concerns. But that's my thought.
No, absolutely. And kind of along those lines, if you have had a tear before, so say with your first you had a vacuum or you didn't and you just had a significant tear, that area heals really well, but it is a little bit weaker. It is scar tissue. And so another risk is if you've already had a tear, it's not uncommon to tear along that same area again. It may not be as significant or severe,
Right.
but I know sometimes moms that are like, this is my 5th baby, I should not be tearing. It's just if you every single delivery
Scar
you tear,
tissue doesn't stretch.
Yeah.
Just like we're in our VBAC talk, and the reason why someone's at chance of their uterus potentially tearing, that 1% risk is because scar tissue doesn't stretch like the regular tissue.
Yep.
An episiotomy may increase someone's risk. And we'll talk about episiotomy. And let's briefly go over the rest of these. So what's going to increase your risk for these more advanced degree tears? And we'll talk about what's an advanced degree. But forceps, vacuum, and episiotomy, increase baby size, makes sense. Potentially if it's your first baby, maybe certain ethnicities might have an increased chance, maybe a smaller perineum or such. If someone's labor is induced or augmented, which means augmented just means helped out or helped progress.
assisted, yeah.
They say things like epidural use. I don't know.
I mean, anecdotally, I don't know that epidural use increases the tear.
I think it just kind of like we were saying before, epidural associated potentially with a longer, more
Prolonged pushing.
Yeah.
But then you don't have to feel it. So, you know, there's some big upsides to that too.
And so, now that we talked about that, let's just do a brief overview of anatomy and the different types of tears, 1 through 4. Let's just go over the tears.
Yeah. So again, tears can happen a lot of different places, but the ones we usually focus on and the ones that most of the time are going to need stitches or repair is going to be the ones that are on the perineal body. So that's below the vagina, in between the vagina and the anus. And they're classified kind of depending on how far they stretch. So there's a first degree, which is just the vaginal epithelium to the perineal skin only. So it's basically like scratching the skin a little bit. Some of these don't even need repairs. They can be hemostatic or non-bleeding, and you just kind of watch them. There's sometimes that being caveat, sometimes I will use stitches in these areas just to make sure anatomy comes together nicely. And that's usually a conversation I have with the patient depending on their pain control. Second degree, which is the most common type of tear, I would say, especially in a first-time mom, involves the perineal muscle, but doesn't go down to the anal sphincter. So what that really means is you now have, it's like if you cut your arm and it's not just the skin, but you've gone into the muscle underneath, and muscle tends to bleed. So these are usually, if not always, repaired. In the U.S. and at our hospital, they're always repaired to restore anatomy, but also to make sure that you're not having bleeding. Again, there's a lot of vascularity, a lot of blood flow that goes to this area. These tears heal incredibly well. And so very, very normal.
I can't imagine a world where I wouldn't want to repair a second degree.
Yeah, no, I I wouldn't either, but I guess I realize I shouldn't speak for the entire world on that aspect.
I mean, there might be resource deficient areas or before there's, but anyway.
But interestingly, even way back, like in, medieval times or whenever you want to talk about it, if women kept their legs closed, this is going to sound extremely paternalistic of me the way I said that, but these areas heal on their own anyways. So as long as you're not getting into the anal sphincter, the muscle in the skin, if left out of being stretched, will tend to heal because it's in such a whatever birthing position you're in, the tissue's kind of stretched apart. Yeah.
But most normal everyday position is with it not. So
Yes. And we repair it. But sorry, going on to the third and fourth degree.
So we talked about that the chance of someone having a tear in a delivery is about 70%. That's mainly those first two options. Only about, I think, I have it right here, 6% of the deliveries might be a third or fourth degree or more severe tear. And really, third degree is, we'll talk about third degree, is when that tear starts to go into the anal sphincter. And we can break this up to, it starts to tear just a little bit. And we divide this up into A, B, C versus all the way through, might be a C. So third degree, definitely what we are concerned about here is the ability of that sphincter to work to its normal capacity in the future. And
what does the sphincter do?
It prevents stool from coming out.
Oh, okay, so quite important.
There's two sphincters actually, and spoiler alert. Hopefully, we'll have somebody on this podcast soon to teach us more about anal rectal anatomy. But there's two sphincters: the external sphincter, which is the one that we're talking about, that mainly controls. Actually, the internal sphincter mainly controls a lot of the involuntary retention of stool, and the external sphincter controls that too, but that's more of the voluntary clench with the external sphincter. But like the worst third degree tear would be to tear through both of those. Fourth degree tear, now, third and fourth are both bad, but to me, fourth degree is more exponentially bad. And this is when you're actually tearing through your sphincters and tearing through the rectal mucosa. So you're within the rectal canal now, and that all is kind of one opening. And so this is where really someone has a significant increased chance of potential issues with not only pain, but also inability to hold in their gas or flatulence, or hold in their stools in the future, some incontinence in both of those potentially. And so both of these will usually involve a more integral repair.
Yeah, for sure. And I've seen, I'm sure you have too, I've seen people who have had third or fourth degrees in countries or places where they haven't been repaired, and those don't heal on their own. So whereas a first and a second probably, it's going to be more painful and involved, but it'll probably heal on its own. Third and fourth degrees don't, and that does leave you with potentially lifelong incontinence.
Yeah. Luckily with repair, that chance is still low, but it definitely can be a potential consequence.
And the risk of those third and fourth degrees, again, is low within itself. So I know when we talk about this, it sounds super frightening, but the risk is low. And then if repaired correctly, now you have an extremely low risk. So don't be scared by these.
Especially the first and second, I think patients are often worried about this. I'm going to tear, oh my gosh, but not all tears are created equal. And I think that's our take home point for this, is that it's a very good chance of your first delivery of a first or second degree tear. But the nice thing is that area heals so well. Usually no one is going to have any issues with the repair of their first or second degree tear. And that's going to be less than 5% chance of a potential complication going forward.
Yeah.
Whereas a third, especially a fourth degree, might have significantly increased risk, 20 to 25% chance of that, an infection or wound separation. And then not to mention that, potential issues with pain, fistula formation, which would be a connection between the bowels and the vagina, or pelvic floor.
Yeah, and there's even about a 5% chance of recurrence. And so, again, not so much
in a subsequent delivery.
Yes. Yeah. Sorry, not just randomly happening to you.
Shoot, it happened again today.
Yeah. Definitely let someone know if that happens. No, but if you may hear your provider talk about a primary C-section if you've had a really bad fourth degree, or especially if you had complications after, to avoid that recurrence risk and those complications subsequently.
Yeah. It's a decision to have at a later time down the road about whether or not, if you've had a third or fourth degree, do you want to have a C-section to avoid the chance of this happening again? Because like we said, if there's scar tissue there, the chances are that tissue won't stretch as well and it could happen again. Only 5% chance, but with each time that area is injured, increased chance of the the incontinence issue.
And just while we're talking about all these things, I remember every morning when I round on patients and talk to them and they've had tears, one of the biggest fears is having a bowel movement for the first time. And I tell people, again, especially with first and second, it's not going to fall apart. Things aren't going to open up. Everything's going to be totally fine.
Yeah.
And if I'm talking to you and you're in that spot right now, you probably will not believe me because it seems like it won't, but it won't.
We'll talk about ways to hopefully make that better and less fearful going forward. But I just want to touch a little bit on episiotomy because it's a big topic of discussion and probably rightfully so. And so we'll maybe toss another little image up there. But episiotomy is basically when the provider cuts that area where the tear would normally happen along that posterior vaginal wall and the perineum. And they started doing it in hopes that it would maybe direct the tear more and make it easier to repair because it's a cleaner cut versus a tear apart. But then, I think what happened is that it was way overused and it became routine. And so someone would get that even if they maybe wouldn't have even tore at all potentially. And so which may have led to some overuse. I think
totally agree. Yeah, it's not. So episiotomies, people will often ask me about them and I don't do them unless
it's really
it's extremely, I've done probably less than 5.
Right. I mean, right. And so you do hundreds of deliveries a year. And you've been doing this for some years.
8 years now? 8 years? That's not including residency, so 12?
Yeah.
A while.
And she count 5 of them. Yeah. I mean, there are some situations where it might be necessary and so in which case we know, but I think most people can walk into their delivery hopefully knowing that an episiotomy is likely not going to happen unless there's significant concern for delivery or for baby.
Yep, super, super uncommon. And one of those, by the way, was someone who requested I do an episiotomy and wanted to see me do it in the mirror. So really very few.
To each their own.
Yes. And if that's what you want, patient autonomy, you can request an episiotomy as well.
Right.
That being said.
Because I imagine like her mom had episiotomies and everything. So she was familiar with it and knew it. Anyway, I don't want to speak for them.
But yes. But there are 2 different types of episiotomies that we do. So one is a midline episiotomy. So it goes straight down, kind of along that same line where we were talking about the tears, the 1st through the 4th degree tears. Mm-hmm. And then the second one, it was called mediolateral. So it goes.
We'll show on the picture.
Yeah, it'll be a little bit easier, but it goes off to the side. And there's benefits and minuses to each. So a midline is kind of more along the anatomical place that people normally tear. So benefits are repair-wise. It's a little bit easier to repair potentially. Downsides is it can extend. So if, just like we were talking about scar tissue that wants to tear again, you can have the same thing with an episiotomy. If you've already made a bit of a tear, it's more likely to have that weaker area up front that'll extend into a 3rd or 4th degree. Mediolaterals, you're never going to get a 3rd or 4th degree because you're going in a different trajectory, not towards the anus, but you are cutting through muscles that have a lot of nerves. And so it's potentially increased pain with that mediolateral. Yeah.
The more lateral you get, or more to the side of the vagina, you get the more potential muscles, nerves, things like that, like you said.
But rest assured that it's unlikely to have an episiotomy. And if you did, it's probably for baby safety. And there's a good reason why we're doing them at this point.
It wouldn't be wrong to just talk to your doctor, whether it's your doctor or the doctor is delivering you, about episiotomy and asking them if they routinely do them, because I think there are potential providers that might, and so you can have that conversation.
Totally. Yeah, I'm gathering from the cohort of people I work with, so I can't speak for every person out there. So how can we prevent it? So just in general, how can we prevent tears? Obviously, we can prevent episiotomies by not doing the episiotomy, but tears outside of that. So there's a couple proven ways to help decrease tears. One is perineal massage. So this is something that you can start at 34 to 36 weeks, or you can just even do at the time of delivery. But basically, it's taking your finger or your partner, because I know it can be kind of hard to get to that area, and putting pressure just to like the first finger joint, so like the pad of your finger, and you're going to rub it back and forth between like 8 and 4 o'clock on the bottom of the vagina. And you can even use, so if you're using your index finger, you're using thumb and kind of press along the perineum or the outside skin at the same time, just to kind of help decrease that area. You can use lubricant if you want to, whatever's comfortable for you. This is something that I've heard patients who absolutely swear by it and their partners have done it every night. I've also had patients who were like, I tried it once and that was weird and awkward and not going to do it again.
It can be a potentially awkward, you know, you can make the most of it. Yes. With the partner, and a patient can try to do it on their own, but reaching around the belly, trying to get that where you do have one or two fingers, like I said, in the vagina, just barely, but now pushing down towards the rectal anal area. That's how you stretch that tissue where it might tear. And so hopefully that tear or the stretch of that tissue can hopefully accommodate the more stretch during the delivery.
Absolutely. And if you're going to try this, probably even reaching from behind and like being on the couch in like a side lying position might work a little bit better than trying to get around from your belly.
Yeah.
And be mindful of fingernails, just on a side note there. The other thing, though, is at the time of delivery, people or your provider can certainly do perineal massage. So I personally do a lot of perineal massage depending on how quick babies are delivering, especially the time of crowning. So also just kind of relaxing that area.
Mm-hmm. Yeah. Can be a nice little easy way. And even in that same process, I mean, someone could ask their partner to do that in the delivery room. They could ask the nurse to do it or the provider. Any of those persons can do it.
Yeah. So perineal massage definitely can be helpful. It doesn't mean that if you do perineal massage, you will not tear. There's always, you can always still have a first or second. Oh no, I was going to go to that next. Oh. But all these preventions, sorry, just in general, all these preventions are to help decrease the risk. It doesn't mean it's a guarantee not to have any tearing. But yeah. So other things.
To the next one, segue. That was just a little too soon. Warm compresses during the delivery. You mentioned you can do the perineal stretch during the delivery, but also you can use a warm rag that goes on the perineum in the time of or around when delivery is going to happen. Now, it doesn't. If you're having an induction, you don't have to do it for like 24 hours. This is mainly usually when somebody's kind of around that pushing phase, where you're using the warm towel, water compress on that area intermittently, and to help again loosen those tissues and hopefully accommodate. The thing with these both is that they really aren't going to necessarily like increase your risk of a tear altogether. And so if you do this and you're like, oh, I still tore, it's not good for anything. Well, the idea is that it hopefully reduced your risk of those higher degree tears, the 3rd and 4th degrees.
Yep, absolutely. And then birth position as well. So potentially being more upright or in a lateral position can decrease your chance of tearing. I don't know that anecdotally I've seen that.
No, I agree with that statement. I think this is potentially like if someone everything's going well, you have the freedom to do the birthing position of choice. But if you're in a more potentially intervention filled delivery for whatever reason, you're probably going to be more in a certain position. And so that's, I think, how. Anyway, so not great evidence behind that one, or delayed pushing is another one that I see out there. Not necessarily at a proven intervention, but something you could try. And I do like to do delayed pushing or laboring down, is what we call it. I think it's a great way to hopefully have a better experience, and this could be a benefit, but not that well supported by evidence.
I do think head control and how quick you push baby out can be part of it too. So that's kind of both the laboring mom and the provider standpoint, just having a slower delivery of the head to allow for that stretch versus a very rapid push out can be really, really helpful. So it's one of those things that if you're able to listen to the provider's cues telling you how quick to push at the time, then that's really awesome. And I'd highly recommend it. I totally understand if it's not what you're able to do at the time and you just need to push as you do.
I think there's so many, I feel like providers that do coach on that slow, controlled push towards the end. I not that I know that it's supported by any, hopefully maybe it gets supported by a study, but I haven't seen anything yet. But yeah, I agree with it. I do too.
Yeah, I think it can be really, really helpful. I don't think it's been studied.
Yeah. And the idea is, the head isn't the culprit of the tear. Sometimes it can be the shoulders of baby. And so once the head's, delivered, you kind of control that shoulder, because sometimes the baby does want to do like a thing like this. And that just increases that diameter of baby trying to come out, which could increase your chance of tear.
Absolutely. So I guess the next part that we talk about is if you have about 70% chance of having a tear, what do you do about it once it's been repaired? And there's a lot of different things they're going to do in the hospital for you, and we send you home with things. But first thing is just know if you look down there, you're going to have swelling, and healing can take a little bit of time, and it's going to look different than pre-delivery. Even if you don't tear, if you look down there, you will have swelling. So I often don't actually have women look right away because I think it can seem a little bit terrifying. But
You're going
it just
through
changes.
so many different emotions at that time.
Yes.
You don't need to see that one of the most intimate parts of your body is different than what you're used to.
Yes, but it's totally up to you. So if you want to look, just know that it might not look like it did, right before delivery. And then we also have medications. If you want to go into different.
Sure. So the different things that you'll often get at the hospital and will be good to use at home is a little spray bottle to use before and after going to the bathroom, because those tears, if the acidity of the urine gets on it, can be quite symptomatic with pain and burning. And so sometimes you give a little pre-spray with the spray bottle and then one afterwards to get any of that off. And you're really just not going to want to really wipe the area either, because that, any dry substance on that area might feel pretty abrasive. So spray bottle is good. There's also the dermaplast spray, which is basically like almost a numbing type spray that you can put on. But you're also going to be wanting to do ibuprofen, Tylenol, or you potentially around the clock for the first few days after delivery, and as needed then after. Some tears, if they're worse, you maybe even need a stronger pain medicine. You're going to have to talk with your doctor regarding that. Obviously we want to be diligent with our use of narcotic type medications, but for some, this might be needed. But you have to be careful because those might further constipate you. And which brings me to my next point. Whether or not you do have a higher degree tear, you're going to want probably some stool softeners, maybe some fiber supplements to make things a little easier, as we were talking before. But I imagine you probably send your patients home with more than a few stool softeners type things. So because it might injure the area, is that correct?
As far as
like if someone had a 3rd or 4th degree,
yep,
you're not going to want them to strain for a while.
Yes, I actually send everyone home with stool softeners unless they don't want them.
Very nice of you.
But especially 3rd and 4th degrees. And the biggest thing about 3rd, 4th degree is, just on a quick side note, is if you are having trouble having a bowel movement, stool softeners that you take by mouth are great. I don't recommend any suppositories though, or putting anything rectally. Not that I don't know that you would want to, but I know constipation when it gets really bad can become desperate measures, but I would avoid any sort of suppositories.
Be in close contact with your provider if you do have a higher degree tear, and they'll probably actually see you sooner than the normal postpartum visit.
Yep. And then non-medication wise, I think it's always nice to have like a waffle pillow or like a little bit of a pillow that disperses pressure, so that you're not putting all the pressure when you're sitting right on the perineum or right on the tear that's there. And just being mindful, on a total side note, when you drive home, don't take like the super pothole road where you're bouncing all over the place. Probably not great for baby either, but also your pelvic floor might not appreciate that. And then last, pelvic floor PT. So I am a huge proponent of pelvic floor PT. I think it's great to see them ahead of time. They can even assess to see if you have a tighter vaginal opening and give you recommendations on how to help with that perineal massage or just relaxation ahead of time before. And then postpartum as well. They just help strengthen those muscles. So your pelvic floor goes through a lot in pregnancy, which is a whole different talk. But again, I think that can be extremely helpful for tears, for repairs, for prevention, all of it.
Yeah, it can take months to potentially get in to see a pelvic floor PT, depending on which area you live in. And so doing that sooner than later, definitely beneficial.
Totally.
So yeah, anything else you want to add?
No, tears happen. Don't be scared by it because it's how you have a vaginal delivery and you get to meet your beautiful child. And so...
And the area heals well. Like we said, don't look at it for a week, but after about a week, a lot of that swelling will go down and the areas will look and feel a lot better.
The only other thing I would add is if there's any dads listening to this podcast, remember what you say can make a lot of impact on your partner. So if you look and you're like, oh, it's very different, just be mindful of what you say, be complimentary, you know, just some side notes there. The last thing you want to hear is, oh my gosh, what happened down there? So dads out there, just keep that in mind.
Yes. Always be very conscious of that. And then, yeah, I mean, sometimes there's a slight adjustment in normal, but you know, this should get back to that normal.
Absolutely.
Well, that's it for today's podcast. Thank you for listening and viewing. If you have any questions, please let us know in the YouTube comments, and visit the YouTube to check us out and some of these images and videos. But as always, the podcast content and the content of the video are all for educational purposes. None of the content is meant for personal medical advice. Please contact your medical provider if you're in need of personal medical advice. Thank you, everybody, and have a great day.
Bye.